All right, everybody. I think we're going to go ahead and get started. Welcome back to Grand Rounds. I'm really excited to have everyone here in attendance. Just as a reminder, if you folks have questions for our presenter, feel free to put them in the chat and I'll be monitoring them so we can make sure they get addressed at the end of the presentation. Before we get started and before I introduce the speaker, I would like to introduce Dr. Jason Best, who's going to give us a little introduction to the joint Global Health Grand Rounds because this is our first session of the academic year. So I'll hand over the platform to Dr. Best.
Thank you, Dr. Crum. And again, we'd like to welcome all of you to this very special joint Global Health Grand Rounds hosted by the Department of Medicine and the Department of Global Health. This is particularly a very special Grand Rounds because it kicks off a series of a number of global health related Grand Rounds for this academic year with numerous clinical departments, including medicine, surgery, psychiatry, pediatrics, and others. For this academic year, the Department of Global Health and the Department of Medicine will jointly host two Global Health Grand Rounds, including today's lecture by Dr. Matthew Hollon, The Unequal Burden of Climate Change on Health. The second joint Global Health Grand Rounds will be held in the spring and will be on global oncology. For more questions on future global health related Grand Rounds, please visit the University of Washington's Department of Global Health webpage. And with that introduction, I think I'll just pass it back off to you.
Perfect, thank you. Well, I'm very excited to have Dr. Matthew Hollon with us today. He has graciously decided to kick off our Global Health Grand Rounds. And so he, just a little bit of background, he actually got his medical degree from the University of Washington and then completed his internal medicine residency at UW's Boise Primary Care track. And subsequently also got his master's in public health and eventually joined faculty at Providence Internal Medicine Residency in Spokane, where he's an associate program director. He's also one of the first college heads in Spokane for the University of Washington School of Medicine as part of the UW Gonzaga Regional Health Partnership. He's currently a trustee of the Washington State Medical Association and a governor for the Washington chapter of the American College of Physicians. So we're happy to take a little bit of your time for you to present on this very important topic. So feel free to go ahead and share your slides and take it away.
Great. Thank you to both of you. I'm going to go ahead and fire up the slides here. I'd really hope to be back in Seattle with all of you, but I'll join you by Zoom and across the region, obviously, across the WWAMI region. As I was saying to Dr. Bestie at this before we got started, my roots are deep here and sharing a few stories about our connections. So I also want to give a shout out to Dr. Ken Steinberg for planting the seed for me to do this presentation today on what I think is what we know to be a crucially important topic going forward. So I have no relevant or irrelevant disclosures. And I'd like to take just a minute to provide a short preamble explaining how it is that I'm with you today presenting Grand Rounds on climate change. Because as you might know, I'm not an international climate scientist. And for those of you coming up in medicine, hopefully this preamble in my talk today impact how you think about your own career trajectory and your work as a physician. I feel fortunate to have this work sitting at the intersection of several significant threads in my nearly 25-year career. For the first thread, I asked you to think back to a time in your life or the last year or just the last week when you've been inspired by or rejuvenated by spending time in the natural world. Whether that's the smell of the linden tree in late spring, a flower, the taste of a huckleberry, a quiet forest, a sunset over a frosty mountain lake, snowfall, the sound of ocean, or standing atop a peak in the Cascades, or the Selkirk Mountains in northeastern Washington and North Idaho, which you see as my backdrop. Now raise your virtual hand. I can't see them. I wish I was able to. If you have felt this inspiration, this rejuvenation, maybe even love for our planet. I presume everyone or nearly everyone raised their hands, right? The fact is we are creatures of the natural world. We depend on the natural world. And as inhabitants of this planet, our fate, the fate of humanity, is inexorably tied to Earth. If you understand this, then you, like me, are an environmentalist. I come at this work in part because I believe that we have a responsibility to take care of our home planet. And anecdotally, I thank the late astrophysicist and my childhood hero, Carl Sagan, for helping me to understand as a young boy watching his public television show, Cosmos, this principle. I also come at this work from longstanding expertise in population biology and public health. I pursued my MPH precisely because I recognized that an understanding of health at the population level was critical to my approach to doctoring. While I have not made public health my career has primarily been in medical education, my public health training has informed every aspect of my work as a physician, and particularly as a primary care physician, where I see critical intersections between the health of our planet and the health of populations and the health of my patients, intersections that I'll highlight toward the end of my talk today. Lastly, I come at this work as a physician advocate, and I offer my deepest thanks to the American College of Physicians and all of you who have supported me as governor for giving me a platform to carry this advocacy work forward. And this topic of advocacy is one I will return to today to close my talk. Okay, enough preambling. Let's get going. So here you can see that the world's 5 warmest years have all occurred since 2015, and 9 of the 10 warmest years have occurred since 2005. 2019 was the 2nd hottest year on record in recorded history. And here in front of us, you can see the unprecedented levels of global atmospheric carbon dioxide, unprecedented in the entire history of our species, and even likely in our predecessor species, Homo erectus. And I think we must recognize, as do 97% of climatologists, that this change is a result of human activities, particularly fossil fuel combustion and tropical deforestation. So here in front of you, you can see that about 3/4 of greenhouse gas emissions are a consequence of carbon dioxide from fossil fuel and industrial processes and from land use in the red. And unfortunately, recent years and recent decades have seen this accelerating. Half of anthropogenic greenhouse emissions have occurred just since 1970, and they have continued to accelerate. And the trend toward decarbonization of the world's energy has been reversed primarily by increased coal combustion since 2000. We recognize that economic and population growth have contributed most to increases and have outpaced improvements in energy efficiency, albeit we're making important gains that we can return to in our discussion on that front. So in the most recent Intergovernmental Panel on Climate Change, that was the 5th report, the conclusion was human influence on the climate system is clear, and recent anthropogenic emission of greenhouse gases are the highest in history. Recent climate changes have had widespread impacts on human and natural systems. And the reality is that temperatures are rising faster in the northern hemisphere and most dramatically in the Arctic. So no arguments about the facts. CO2 is at unprecedented levels due to fossil fuel from humans, which are leading to global temperature rises. And now we'll turn our attention to the health consequences for humans. These health consequences are wide-ranging. And what I want to bring us, before we visit the exactly what those consequences are and then do a deeper dive into several of them, in terms of framing our conversation for today, we have to think about sort of two key concepts. The first concept that I want us to hold in our minds today is the concept of vulnerability. Vulnerability being the balance between exposure risk and susceptibility and adaptive capacity of populations. So we should recognize that the most vulnerable populations, or the greatest vulnerability, occurs in the face of greatest exposure and greatest susceptibility and least resiliency. The other concept that is important for us to understand is this concept of injustice and environmental injustice. And we should recognize that when there is disproportionate responsibility for cause and disproportionate impact, particularly on the most vulnerable, that is the clearest circumstance of injustice. There are other circumstances, but the clearest one is that disproportionate responsibility for the harm and disproportionate impact on the most vulnerable. And widely recognized that key vulnerable populations include those listed in front of you. Returning now to the areas in which human health is impacted by climate change. We oftentimes will use this CDC diagram to capture sort of the core impacts, including severe weather, air pollution, important changes worldwide in vector ecology, including dengue, increasing allergens, water impact, food and water supply impacts, other environmental degradation, and extreme heat. And it's important as we move forward to recognize that climate change will affect communities differently and create novel impacts that have not been witnessed before in terms of how we think about traditional environmental research. So here, recognizing that in the Northwest, we're certainly spared, at least so far, the impact of hurricanes. Although in Washington state, West Nile virus cases have increased substantially. We'll do a deeper dive later on into the impact of extreme heat. That'll be our first sort of detailed dive. Another way of thinking about the variability is to think about particularly vulnerable groups. And our focus topics today are going to be heat stress and air pollution, recognizing that, as you'll see, the elderly, those with chronic medical conditions, both urban and rural poor, outdoor workers are special populations adversely affected by extreme heat events. And recognizing that for air pollution, populations that are known to be adversely affected, including those with pre-existing heart or lung disease, again, outdoor workers and children. So as I mentioned, our focus today will be first on extreme heat and air pollution and the unequal burden that's borne by these impacts of global climate change. I want to highlight that I am relying principally for many of the conclusions on the work done by the US Global Change Research Program. The Global Change Research Program comprises 13 federal agencies that conduct or use research on global change and impacts on society to support our nation's response to global change. And they've been instrumental in modeling and thinking about the health impacts of climate change, both in the United States, where most of their work is, but by extension across the world. So I'll reference these on several occasions. I'm going to start by talking about the impact of extreme heat. And first we'll think about the ways in which global climate change are amplifying exposure to extreme heat events. So we now recognize that mean exposure to these extreme events has more than doubled since 2000. And the number of vulnerable people exposed to heat wave events hit a record of 175 million people in 2015. If we keep global warming to just 1.5 degrees Celsius, so that's not even IPCC's goal of below 2 degrees, we recognize that that number of 175 million people will climb to 350 million people exposed to deadly heat by 2015 under sort of mid-range population growth scenarios. And in a climate held to 2 degrees above to historical average, places like Karachi and Calcutta and Los Angeles, as we saw last week, could expect conditions equivalent to their deadly heat waves of 2015 when the temperatures were 120 degrees every year. None of this factors in heat stress metrics that integrate rising humanity, and those show even more dramatic risk. This has been modeled in US communities. Here, data in front of you looked at heat waves, and here they defined, heat waves are variously defined as temperatures above the 90th or 95th percentile of average. Here they looked at temperatures above the 95th percentile of average for greater than 2 days. And within each community, they estimated the mortality risk during each heat wave compared with non-heat wave days. We'll return to this concept of how we understand the adverse impacts of heat and the related mortality risk of heat in just a minute. But using this data, you can see that on average, for every 1 degree Fahrenheit above average mean temperature, mortality increased by about 2.5%. And these impacts actually of heat across broad geographic regions help us to understand the human toll of heat waves. Many people don't realize that in the United States, extreme heat causes more deaths annually than all other weather events and natural hazards combined. And actually, this number is, as you'll see, is just directly attributable fatalities. In fact, fatality is probably much, much more substantial than that. How do we know that? Here's data initially helping us to understand the heat, extreme heat related mortality. This is data from the extreme heat wave in the upper central Midwest in 1995. And in general, this is the way in which people have understood and sort of modeled the adverse impacts of heat on populations, particularly as it relates to mortality. So at any given time, from a population health perspective, right, there's tends to be sort of a background rate of mortality that doesn't change too much unless you're in the middle of a pandemic or a heat wave. And what we've understood is that, and what's shown in front of you is this data on excess deaths compared to usual. And what's particularly interesting about this data is that so that difference is known as the mortality anomaly. And what's particularly interesting is that while there are a certain percentage of those deaths that are classified as heat-related on death certificates, the total number of excess deaths typically exceeds even ones that are identified as heat-related, and likely results as a consequence of how we understand the ways in which extreme heat can lead to increased cardiovascular death primarily, so not captured necessarily. And so this is just data from Chicago at this time. So we remember back a slide or two, we estimated that for every degree above average, you see about a 2.5% rise in mortality. Mortality risk during this heat wave compared with non-heat wave days, and not just, this is for the cumulative effect, was 133% above traditional non-heat wave days. So these extreme heat events are really amplify the risk. So it's not a linear risk is the easiest way to think about that. And more accurate estimates of comparing sort of observed mortality during heat waves versus expected mortality have gone on to recognize that we are typically talking about excess deaths of tens of thousands. So best estimate for 2003 European heat wave was 70,000 excess deaths, 15,000 for the 2010 Russian heat wave. And so modeled by the US Global Change Research Program, they note very likely and with high confidence that future mortality in the United States will be thousands to tens of thousands of additional premature deaths, with older adults and children having a higher risk, and people working outdoors, socially isolated, economically disadvantaged, as well as some communities of color bearing a disproportionate burden. So I'm going to turn now to look at some of these populations in more detail. It's recognized that the elderly disproportionately are impacted by extreme heat events. The reasons why that's likely to be include alterations in physiologic responses with aging, likely medication effects, as well as social factors that include functional status declines, isolation, and dependency. Indeed, recent studies of this in this summary paper from Meteoritas, 24 out of 24 studies reported a strong relationship between heat and death rates in the elderly, primarily focusing on cardiovascular and respiratory mortality. And in that 1995 Chicago heat wave, the majority of deaths by far and away were in the population above the age of 65. Here you see ecological analysis that continues to reinforce this. So this looked at, again, at that mortality anomaly. So the rate at which observed deaths exceeded expected deaths during a extreme heat event in Massachusetts. So they looked at that by counties and geographic areas throughout Massachusetts, and then were able to correlate that excess, that mortality anomaly, and found that it correlated with the African American or Black American population and elderly. If you look at some interesting data that just brings us back to sort of vulnerable populations and helps us to think about the impact that heat may have. So this is Medicare data, Medicare inpatient billing records from 114 cities in the United States from 1992 to 2006. And they looked at the association between extreme heat events and all-cause and cause-specific hospital admissions. And what you'll notice here, it's easiest to look at the sum of the main effects down below. And what you'll notice, and none of this crosses, all of these confidence intervals are statistically significant. What you'll notice is that there is definitely increase in hospitalizations as a consequence of heat. However, interestingly, there is what they describe as a strong and deleterious association with cardiovascular mortality that's essentially protective against hospital admissions, and postulated that heat-related deaths are actually primarily sudden cardiac death, and individuals who otherwise would have been hospitalized for cardiovascular disease actually die instead as a result of extreme heat. But what makes sense then is this robust relationship between making it to the hospital and being admitted for adverse renal effects. So increasing data now about the relationship also between heat and renal disease, again showing significant impacts, including impacts on mortality. We've also seen epidemics of kidney disease that have received attention in Central America in recent years. Now, having generally reviewed the health impacts, particularly as they relate to mortality between extreme heat, I'd like for us to do a little bit of a deeper dive into exposure. So we've talked now about susceptibility to heat. We're going to focus more on exposure. And we're going to look to our sister city to the south, Portland, Oregon, and an interesting study out of there where they looked at heat exposure among socio-demographic groups using census block groups. And they took a heat event that happened in Portland and took 60,000 temperature measurements by driving a fancy thermometer across transects of the city, and then looked at the relationship between where heat exposure and socio-demographic groups within these census block groups. They also simultaneously looked at access to refuge, public refuge facilities. And the concept here is really centers on this idea of urban heat islands, right? So we recognize that as I think all of us have experienced in moving through cities at various times, that things like impervious surfaces, anthropogenic activity within cities, and the scarcity of elements such as trees or grass that can be heat ameliorating can amplify temperatures spatially within cities, and particularly have a significant impact on nighttime temperatures, which actually many people think plays an important role in the impact in the adverse impact of heat. And here's what they found during this period of time. So you can see temperature recordings over here on the left. And as they took these 60,000 readings throughout the city of Portland and correlated those with the demographic characteristics of census block groups, you can see that the population disproportionately exposed to somewhere between sort of 2 to 3 to 4, almost 4 degrees Celsius higher temperatures, were low income, non-white, less educated, and oftentimes English was not a first language. Importantly, in Portland, at average walking speed, only about a little less than 1 in 5 people would have access to public heat refuges. So this is really about that adaptive capacity piece. So if we think back to vulnerability being that combination of susceptibility, exposure, and lack of adaptive capacity, this plays an important role. And their summary data is here in front of us. So the easiest way to look at this table is to say for every doubling in the number of white people within a census block group, the average temperature would be 1.5 degrees Celsius lower. And for every doubling of the number of Black people in a census block group, the temperature would be 2 degrees Celsius higher. Interestingly, there was not a relationship, and they comment on this specifically. There didn't seem to be a correlation or the correlation was in the negative direction for elderly, and had a lot to do with the fact that elderly were not, they were more spatially distributed. So you can see increased heat exposure based on key sociodemographic factors. Children had less access to air conditioning. On a positive note, there was, in terms of that adaptive capacity, a population at higher risk of exposure actually had better access to cooling centers. And here's the probably really the most important piece of this. For those of you, we're not going to do a deep dive into this, but I strongly encourage all of you to look at this New York Times summary. So it turns out that a lot of these urban heat islands that we see and this disproportionate exposure are actually a legacy of decades of racist housing policy. So in the 1930s, the federal government created maps of hundreds of cities, rating the riskiness of different neighborhoods. This is Richmond, Virginia in front of you. The riskiness of different neighborhoods for real estate investment by grading them best, still desirable, declining, or hazardous. And race played the defining role. Black and immigrant neighborhoods were typically rated hazardous and outlined in red, denoting what they felt was a perilous place to lend money. And for decades, people in these redlined areas were denied access to federally backed mortgages and other credit, fueling a cycle of disinvestment. Even in areas that are outlined in yellow, they were rated as declining. And an example of just the overt racism, the appraisers in Richmond, Virginia, wrote in denoting an area as declining that Black families sometimes walked through on their way to taking children to school. This legacy then plays out here. That federal policy informed the homeowners loan corporation as to where they would support investment in mortgages. This is data from Baltimore in 2018, distinguishing these historical HOLC class areas, D being hazardous and C being declining, and clearly showing marked differences in exposure to the land surface, estimated land surface temperatures during a heat wave. So grounded in fundamentally racist policy. I'm going to change gears now and just something that's obviously hitting close to home for all of us in the last 15 minutes and talk a bit about air quality. So, and its relationship to climate change. So the World Health Organization estimates that ambient air pollution causes millions of premature deaths worldwide. And we recognize that climate change leads to increases in multiple components that determine air quality. This includes heat and allergens and gas, ozone in particular, and particulate matter, particularly particulate matter 2.5 microns. And synergistically, those work to harm human health. This has been fairly laid out by a whole host of researchers that air pollution produces lung inflammation, which produces inflammation, which causes, importantly, heart attacks and strokes. Much of that work, I think, has been Dr. Joel Kaufman here at UW has done that work. I've been involved in that work. And here's best estimates of the global burden of pollution, recognizing that climate change will only make this worse. 9 million deaths annually, outpacing tobacco, AIDS, malaria, and tuberculosis, and alcohol. Wildfires are particularly potent emitters of particulate matter 2.5 microns, thought to be the most harmful of the particulate matters, as well as ozone, and recognize that these increase the risk of premature death. So again, from the US Global Change Research Program, likely with high confidence. They also note that climate change, as we're seeing today and the days preceding this, will increase the number and severity of wildfires in Western United States. And we know there's clear data that the health impacts of wildfires is significant. Just a few points: during times of peak fire and this particulate matter concentrations, odds of persons seeking care in emergency department increase by 50%. Wildfires are associated with hundreds of thousands of deaths annually. Global perspective on the impact of wildfires. Again, using similar sort of means of looking at observed deaths and over expected deaths. Importantly, I think we recognize the Western United States will be dramatically and is being dramatically affected by increases in very large fires. And if you look at this map, you'll note that many of these areas in the Pacific Northwest are rural communities where we see massive increases in wildfires related to global warming. So now returning to these components of vulnerability, right? We think about susceptibility, exposure, and resiliency. And we recognize that rural areas have greater portions of people living in poverty. There are greater portions of elderly Oftentimes, these are communities where people work outside in agricultural communities. There tends to be less capacity to respond to climate change and barriers in terms of communication, transportation, and other infrastructure. So I think it's clear that rural communities are subject to a climate gap as well as defined by this disproportionate and unequal impact of climate change. And importantly, while historically many people may have gone to rural communities to get a breath of fresh air, fascinating data over the last 2 decades. So this is looking at particulate matter trends in the United States and the incredible progress that was made in the eastern part of our country. This is primarily related actually to a decrease in coal-fired power plants and declining particulate matter 2.5 micron. Again, this being perhaps the most potently hazardous to our health. But note what's happening in the West. That trend of declining levels is not seen. And in fact, we've seen a trend in rising levels of particulate matter. And this is attributed to the growth and spread of large wildfires related to climate change. So I think it's clear that we understand that wealthy account for most of the contribution. Wealthy nations and wealthy people account for most of the contribution, yet the burden falls disproportionately on the poor. And older demographic has cumulatively accounts for contribution to global greenhouse gas emissions, yet that burden falls disproportionately on the youth, and we haven't focused on that per se. Developed countries account for most of the contribution, yet again, the burden falls disproportionately on developing countries and populations that are most vulnerable. So if we return to that idea of injustice being disproportionate responsibility and disproportionate impact on the most vulnerable, then I think we can make an argument without question that climate change is not only the public health crisis of the 21st century, as the Lancet called it, but it's actually also the preeminent climate justice issue of this century, and really honestly, perhaps in human history. So I want to end on a bit of a positive note. I think we recognize now that climate change really can be a win-win. And even a win-win-win. There are economic advantages to reorienting to a low carbon world. So these advantages can include improvement in air quality, hopefully blunting the magnitude of effects that we would see across the spectrum of health impacts, including extreme heat events. There are also sort of these health co-benefits through lifestyle changes that are appropriately support efforts to stop or interrupt or slow, I guess is the best word, climate change. So, recognizing that alternative modes of transportation not only benefit the planet, but, walking or biking to work can actually be helpful. And this is that intersection between sort of primary care and population health and the health of the planet. In that, areas where people are more active, areas where people are more, seek more active transport. We have clear data that obesity rates and diabetes rates are lower. And then the unequivocal benefit of eating lower on the food chain, particularly as it relates to beef. Excuse me. I think it's also important to just take a quick step back and just recognize that while I've talked about heat exposure and air pollution today, there's really not a single system disease. If you go back to that CDC diagram, sort of the wheel of health impacts, we need to recognize that across the board, climate change, compounds existing pressures through multiple channels on housing and food and water security and poverty and all of the social determinants of good health. And that they extend beyond just weather-related disasters is important to recognize. So I'll just close a little bit by talking about our role as physicians, and again, recognizing the important work that the American College of Physicians has done in this front, really defining our moral imperative to educate the public, our colleagues, our community, and lawmakers about the health risks posed by climate change. And to spend a little bit of time sharing with you my own perspective on physician advocacy and activism. So while certainly there have been through the decades physicians who have powerfully stepped into the role of advocates, unfortunately from my perspective, and while there are exceptions, too often this is seemed motivated by self-interest on the part of physicians, not always, but too often. But perhaps more unfortunately, I think as a profession, it seems we've generally shied away from the role of advocacy and activism. Despite being on the front lines and having an understanding of the impact on our patients, of the lack of access to healthcare, the impacts of firearm violence, the impacts of systemic injustice and racism, and as we learned today, climate change. As a group, we seem to have fallen short for our wider potential for advocacy and activism. I've pondered why this might be over the recent years, how we learn to maintain a certain equanimity, and advocacy is often about passion, how we're encouraged to embrace objectivity and sort of remain a step away, even be apolitical. But I ask all of you, when did politics become such a dirty word? In our democracy, politics is the act of self-governance. As physicians, we are respected by our communities. Our thoughts are valued precisely because we are masters of reason, particularly as internal medicine doctors, and generally reasonability. We should participate in our democracy. So please, let's put that reason and reasonability to good use and be involved in the act of self-governance of our communities, our state, and our country. Whether it's as individuals, or if you're brave enough to follow in the footsteps of Dr. Kim Schreier, US Representative from Washington District 8, and my other hero right now. I had a chance to introduce her at the ACP's Leadership Day in 2019 to attendees. So if you're brave enough to follow in her footsteps by running for public office, I'm not brave enough, I'll just put that out there. Or through our professional organizations such as ACP, where we can speak with a unified and effective voice. Let's be political. Let's be advocates and activists for change that benefits all of our patients and our one and only planet. So to summarize, anthropogenic climate change manifests principally as global warming is happening. This is having and will continue to have massive human health consequences. The disproportionate responsibility and disproportionate impact on the most vulnerable is the environmental justice issue of our time. And you all can make a difference. Eat low on the food chain, walk or bike to work, educate others, and given our resources, invest in clean energy, be an advocate, and please vote. These folks have been influential in helping me and the sounding board for putting this work together over the past few years. Both graduates of the University of Washington's Internal Medicine Residency Program, and I'm happy to take questions.
So thank you so much for such a comprehensive and really timely talk. And while questions come in through the chat, there was one question of, do you have a preference or could you speak to the difference of using the term climate change versus global warming when discussing this topic, particularly along the lines of with patients or physicians or in the sense of advocacy?
Yeah, this has been such an interesting and sort of debated issue. You know, I think people backtracked from sort of using the, using global warming as a way both to recognize that CO2 production, it's not just about global warming, it's about acidification of the oceans, it's about, in part, other impacts. I mean, global warming and sea level, is impacting melting ice. And, it was also, I think, a sort of conscious political decision. And, so the language of climate change, I think, is one that is widely used. I'll be honest with you, to me, I go back to, some of those slides and, particularly, let's see if I can, you look at that, if you were in a lab, you'd be like, whoa, that's real. This is real data. And so I've returned to recognizing that a big part and parcel of climate change is global warming. And that it's clear that this is not just about natural fluctuation in the planet, in the planet's temperature. I think it's clear that this is about this.
We have another great question. If you have any comments about the mass migrations of populations resulting from climate change?
Yeah, super. I just think both sad and phenomenally worrisome is the word I'd use. So WHO is currently estimating that if we don't do anything as a species, there will be 1 billion climate refugees by the end of this century. So the time to act is now. And I know I was talking with Dr. Crum and Dr. Bestie a little before this, and the pandemic looms large in our minds at this moment, and is obviously an important thing for all of us to face, and hopefully will ease in the time to come, and we will be left with what's in front of us for decades, if not the entire century. And so the time for us to do something about this is really now.
That's a great point, and I think that what a question that dovetails into that is someone asked, you mentioned investing, and we actually just got a survey today regarding UWP options for socially responsible investing. Could you comment on how these actions may affect change and places we could put our efforts behind?
Boy, I wish I was an expert on that topic. I don't have that. Just to be honest, I just don't have that kind of expertise. I spend a lot of time thinking about my own carbon footprint, and the main things that I feel like I've been able to do are really commit to, active transport, and eating low on the food chain. And in terms of investing, I will say I bought an electric car. And I think, and I'll tell you, that's, to me, having driven that now, that is the future of car. So I think, that beyond that, so clearly, I think I think large corporations, there's a lot of people that get this, and I think there are a lot of opportunities. I'm not an expert in investing.
Well, I'll leave you with one final question that maybe you do have a little more insight on. What are you aware of any sort of physician organizations locally that are active in climate issues? You mentioned ACP, but any others that you're aware of, or other ways to get involved?
Yeah, so first off, Physicians for Social Responsibility has had a long and robust effort in our state to tackle this, and has actually sponsored a lot of really good stuff. I've done talks for them here in Eastern Washington. So PSR, your American College of Physicians nationally and locally, we've done advocacy work. And a huge shout out to the Washington State Medical Association. If you're not engaged and involved with WSMA, they have policy on the books, including, and we totally a topic for another time, but including advocating for the next sort of what environmental community thinks is the next big step is a low carbon fuel standard in the state. So WSMA has been in Olympia and working on this and doing heavy lifting. So it's a great thing, which is brings me back to the role of professional organizations, where we can speak with a unified and effective voice to be advocates and activists. And so please be involved in your professional organization.
Wonderful. I think that is a really great place for us to end your really fantastic talk. And I, again, really appreciate you taking the time to join us. Hopefully next time it will be in person, but thank you again for this really timely and important topic. And hopefully folks can join us next week for our next Grand Round session, which will be with Dr. Rudy Rodriguez, discussing how geography matters, how residential segregation, race, and can impact health outcomes. So also an important topic. So again, thank you so much for this great talk, and thank you for everyone attending. I really appreciate it. Have a fantastic Friday, everybody.